Morning, everyone. I apologize for being a few minutes late. We were just informed, so welcome. Is there any disclosures of pecuniary interest? Seeing none. I just want to welcome Megan Jamieson to our board here. She's a new in her new role as Corporate and Social Services Manager for Halton County. Welcome, Megan. Presentations and deputations, are there any? Seeing none. Could I have adoption of the correction of advisory committee meeting minutes? 4.1 Health and Social Services Advisory Committee, April 24th, 2023. Thank you, Councillor Metcalf, seconded by Councillor Linda. Thank you very much. Councillor Van Hassen.
Madam Chair, there's a little typo on those minutes. 7.2.1. Move the second. The motion was not. I believe it needs that we received. That's not from that.
Thank you. So should I call for a mover and a seconder on that now then? No, it's just clerical. Okay, thank you. Any further comments, questions? Seeing none, all in favor then? Very, thank you. Update on reports.
Through the chair, all reports were approved at council. Thank you.
Consent items. And staff reports. We'll go to 7.1 general manager. Done. 7.2 public health. We have 7.21 acting medical officer of health, Dr. Joyce Locke. Update. Thank you, Dr. Locke, for attending today.
Thank you, and Madam Chair. Good morning, everyone. At the end of my presentation or my talk, I appreciate your feedback. At the last report, I attempted just to give you a little bit of synopsis of what I was doing and to give you some insight into the kind of activities I engage in locally and through my connections through the other networks of public health. And today I elected to provide a little bit of words of hopefully additional insight into one of the reports that is to follow regarding our child health programs. So today I'll just address the Healthy Babies and Healthy Children program, but I do appreciate your feedback later as to what's helpful to you in these reports. The Healthy Babies and Healthy Children program has been around for a long time. It has suffered somewhat in that there has actually not been any increase in the funding to that program in quite a long time. So because of that, and yet I wanted to indicate the very significant importance of that program through this report. And the reason is that it attempts to nip in the bud from the moment a child is born, to be able to identify those families and those children who are at higher risk for what we call adverse experiences of childhood. These are situations which are called toxic stress situations, where a child ends up in an environment where they are continuously stressed due to multiple factors. What they have shown over with multiple studies is that this continuous exposure to toxic stress actually ends up changing the way the brain develops. So a lot of people think that if a child's had a negative childhood, that if you then at a later stage in life move them into a more positive environment, they'll get over it. But the thing is they don't, because the way their brain developed during those critical early years has been changed in how it responds to stress, how it manages stress. Stress hormones such as cortisol remain constantly in high level, and that affects the way the brain develops. So from that, because then they'd end up with poorer skills at managing stress, they are then subject to ongoing issues. And I think that the diagram with the pyramid on page 2 of the report shows that very well. So the adverse childhood experiences result in that disrupted neurodevelopment, the way the brain is developed, which then results in social, emotional, and cognitive impairment. Their ability to build solid, supportive, connected relationships is affected. And so through that, they lose both the social resilience and the emotional resilience that they need to be fully productive and and experience full well-being. And that then, of course, leads to the adoption of these health risk behaviors where they attempt to self-soothe themselves because they can't get it through their ability to develop secure and safe and supportive relationships. They turn to other abusive behaviors. And that, of course, has long-term implications. It's also been shown that these risk behaviors that they then take on or potentially take on has adverse effects in the long run. So they are associated with increased risk for multiple chronic diseases. So this is very old science. It's been studies started about 40, 50 years ago on this. So this is pretty much common knowledge. And so to counter that, programs have been initiated to start to try and identify these at-risk children and at-risk families early. And that's where the Healthy Baby, Healthy Children's program comes in. So it provides, as you'll hear more later, where we attempt to work with our hospitals, with our midwives, and with our family doctors to identify these at-risk families early on and to intervene early into trying to develop healthy, supportive relationships between the parent and the child. And so I'll leave it at that. There is a more intense version of this program. It's called the Nurse Family Partnership. It starts before birth, so it starts in high risk women and high risk families. For the first time the child is a mother, so when they don't have any experience at all, it starts in pregnancy, walks with that mother and the family unit, spouse, well into the second year. And it has a more stringent criteria as to which families are eligible. And it has a much more intensive intervention with regular visits through the first 2 years with that particular family unit. It has been implemented widely through the US and has been implemented in parts of Ontario and parts of BC. And is the Canadian aspect of it is undergoing evaluation. Our program, you'll hear more about it, does use little elements of the nurse family partnership in higher risk individuals, but doesn't implement the whole program. And that's what's done similarly in many health units across the province, just due to an attempt to manage resources, but realizing that the earlier you start the intervention, the better. That's my report.
Thank you very much. Are there any questions or comments? Thank you, Councillor Linda.
Thank you, Madam Chair, and through you. Thank you for your report. And as you said, it's common knowledge. It's something I remember talking about years ago. And where I don't think we've made any progress is the fact with school boards. I think all of this should be something that has to be redeveloped. I think school boards have a particularly important part to play in all of this because it starts at this end and it ends up at this end. The kids that are in early development, there should be governments that see forward thinking and saying when we build new schools, we should have daycares attached to them. So children could start even earlier with positive reinforcement on how good things happen to them in the future. Should be at the other end as well. It should be in the years of high school that more programs are there for young people in high-risk areas to talk about pregnancies and talk about a development when they have children. I know they have some programs, but they're not as highly developed as they should be. And I'm wondering if a letter could be somehow devised to go to the ministry, go to school boards and encourage all of this and think forward when they create new schools. New schools should have, as I indicated before, facilities for daycare. We are short daycare everywhere in the province. You build a school, build an extra 2 rooms. All of this could work to develop stronger families, stronger children that end up stronger adults. And this, again, will have a spin-off effect of in the schools, we have a lot of situations where we have to have special needs, or we have to have extra assistance for the teachers. And it goes on even further into the police services. Because if you take care of a child today, you don't have to take care of what's going to happen tomorrow. So it has a spin-off effect, and I think government should be more involved right from the beginning to the end. And education is the key here. So I think maybe if we could derive something that says to government as well as to board, think for the future instead of being closed-minded and not realizing that we have to take care of the child because that's the future adult. So that's my comment. Thank you.
Thank you, Madam Chair. So realizing the intersection between utilizing the fact that all our children, no matter what economic income or what kind of neighborhood they come from, all go to school, and that they are formative years. There is a group that's called the Code Como group. So Code is the Council of Directors of Education, and Como is the Council of Medical Officers of Health. So there is a group that meets regularly of some of the directors of education from across the province and some of the medical officers of health. And they do work together collectively to attempt to move issues forward of common interest. For instance, the school nutrition program has been something that they've worked on steadily for quite a long time. So I could bring this issue to that table as well. And there is an other working group from Como. It is the Healthy Kids Working Group, which attempts to deal with issues related to children at multiple levels. So I will also spend some time chatting with that group to see what's on their advocacy campaign programs there. So yes, we'd be happy to draft a letter, but I'll probably do it in consultation with some of the other experts among my colleagues who are already working in these areas.
Any further questions? Councilman Parker?
Just thank Madam Chair, and I'm not sure if I should ask this question now or later on when the report comes, but remember all the numbers. There's 1,035 births and 586 were deemed to be with risk under the screening tool, but it ends up only 62 are actually fully deemed with risk. And I wonder, is it about time we adjust that screening tool to sort of get those numbers a little closer the first time so we can put more of the resources where they're needed instead of having resources looking for problems that don't exist?
Yeah, so I think I might defer that question until we have the presentation on this work by the manager. That said, the screening tool underwent extensive revision about 5 years ago. I may be slightly off, but it's not that long ago. So to address that question, I'd have to look more into the work that went behind the provision of the tool and what the expected outcomes were.
there any further questions or comments? Done. Dr. Locke, I'm going to reserve my questions for when we can report, but I just want to thank you for this. And it is a much needed service. We do need to get in there. Even before these children are born, and give service and provide services to these families that are absolutely, we are lacking quite a bit in our services that we provide to first-time moms, to moms at risk, or more funding from the public. Next up is 7.2.2, annual service plan and budget submission, HSS 23025.
Through the chair, I would like to introduce Mr. Syed Shah to present to the report. Thank you.
Thank you.
Thank you. Thank you, Stephanie. So you
Need a motion.
Oh,
Step from-
sorry about that. Could we get a motion on the floor to
Step
approve in a
Rogers
second?
Health.
I'm gonna mess this up again, aren't I? Thank you. So for 7.2.1, we for a seconder to receive the report, please. Thank you, Councilor Linda. Councilor Duffy, thank you. All in favor? Carrie, thank you. Hey, sorry about that. Okay, the next report, thanks.
Thank you. I'll be presenting 2023 annual service plan and budget submission report, HSS-23-025. The Ministry of Health requires submission of an annual service plan to accompany the funding request for mandatory, related, and one-time programs. The purpose of annual service plan is to describe the programs and services boards of health are planning to deliver in accordance with Ontario Public Health Standards based on local needs and communicate budgeted expenditure for a given year. Table 1 will give you an overall picture of total budget submission. There are 5 streams. For mandatory programs, the total budget is around $9 million. The second one is Ontario Seniors Dental Care Program, which is a 100% funded program with a total budget of $633,000. The third one is the COVID General Program, where the total budget is approximately $1 million. We have the fourth stream of COVID-19 vaccine program with a total budget of $1.165 million. And then there is the additional one-time programs where we submitted 6 requests totaling $370,000. So in total, we submitted a total budget of approximately $12 million to Ministry of Health. It is important to note that the annual service plan does not include program funded by Ministry of Children, Community and Social Services or any third parties. We are still waiting for Ministry to approve our budget, so a follow-up budget amendment report will be provided to the Advisory Committee and to Board of Health once approvals have been determined and communicated to the Health Unit. With this, I'm happy to answer any questions you may have. Thank you.
Thank you for your report. Are there any questions? Comments? Done? I get a mover, please, in a second. Thank you, Councilor Duffy. Seconded, Councilor Metcalf. All in favor? Barry, thank you. Next is 7.2.3, Healthy Babies, Healthy Children Program Update, HSS 23017.
Thank you, Madam Chair. With this, I'm going to introduce my colleague, Nikki Loss, Program Manager for Healthy Growth and Development, to present this report. Over to you, Nikki.
Thank you, Syed. And thank you for having me. Through the chair to the members of the Health and Social Services Advisory Committee, I will be presenting Health and Social Services 23-017 Healthy Babies, Healthy Children Program Update. So as Dr. Locke shared, our HBHC program, Healthy Babies, Healthy Children, is designed to help children in Ontario have a healthy start in life and provide them with opportunities to reach their full potential. This program began in 1998, and it's mandated through the Ontario Public Health Standards. It's funded through the Ministry of Children, Community and Social Services and delivered through our HBHC team. Our team consists of a program assistant, public health nurses, and family home visitors. Our team delivers HBHC in collaboration with community partners such as Norfolk General Hospital, Child Protection Services, and other family support programs such as those provided by REACH. For this summary, I will refer to our clients as caregivers as it encompasses all who are eligible. During their prenatal, postnatal, or early childhood, which is 6 months of age up to transition to school, caregivers can be referred to or self-refer to our program. Once referred, our team completes a ministry-developed screen where we determine their level of risk. If they're identified at risk, then we offer them entry into our program as it's voluntary. Together, the public health nurses and caregivers work to develop a family service plan where goals are created. A family home visitor is then assigned to the family and they meet weekly, bi-weekly, or depending on what the level of need is, it can be more or less frequently. Our family home visitors work to support the families with interventions, resources, and connections to community services within the client's home or wherever they feel comfortable. And our public health nurses continue to provide families with more in-depth assessment and support as needed. The COVID-19 pandemic greatly impacted the service delivery for our HBHC program. Almost all of our team members were redeployed to emergency response tasks, and only one of our public health nurses was available to support very high-risk clients. Home visiting was not offered, and the main goal of our interaction was to connect them with support still available in the community and resources virtually if possible. Currently, our team is at full capacity and working hard to reestablish relationships with community partners, gain new education on our current trends in our HBHC client population. Most importantly would be our increased maternal mental health concerns and an increase in negative child behaviors. As well, we're increasing our referral and caregiver updates for the HBHC program. One of our biggest challenges, as Dr. Locke spoke to, is the lack of funding available. The ministry has not increased their funding since 2015, despite an increase in population and an increase in the needs of our caregivers and their families. Although we put forth our best efforts to make do with our current funding, without an increase, we are limited in our abilities to deliver the HBHC program to its full capacity. And this is more true, or especially true, in our vulnerable populations. The majority of our HBHC clients are referred from various external sources, so hospitals, midwives, etc. In 2022, Haldeman Norfolk County had 1,045 live births. Of those live births, we received 899 referrals. 451 of those were for Haldeman and 448 were for Norfolk. 586 caregivers from across both jurisdictions were identified with risk. Another important statistic is that approximately 75 to 80% of our screens and referrals come from outside of our jurisdiction. Many of our quality improvement initiatives involve looking at how to increase the number of screens we receive from external sources, as well as how we can capture moms earlier on in their pregnancy, which Dr. Locke also spoke to the importance of. Despite the lack of funding and negative impact on the COVID-19 pandemic, our HBHC team continues to support caregivers and families of Haldeman Norfolk. We are accomplishing this directly through our home visiting program and indirectly through our community partners and their programs. We'll continue to create awareness, educate, and develop innovative ideas to meet the emerging needs of our ever-growing and changing community. Thank you for your time.
Thank you very much. Is there any questions, comments? Councilor Metcalf?
Thank you, Madam Chair. Great presentation, Nikki. Thank you. Just a quick question. 70% of the, could you elaborate on that? The 70% that came from external sources. So what would that entail? Like doctors or other social programs, or what would that entail?
So it actually entails more hospitals. We do not receive a lot of referrals from family doctors. Our main referrals come from external hospitals like McMaster, St. Joe's, Brantford, Woodstock, etc. Most of our families deliver outside of jurisdiction. Norfolk General Hospital now has a delivering unit, again, as it was closed for some time. So I know they're working on building up their numbers as well. We do have liaison nurses that go into those hospitals, so into NGH, sorry. So it is an advantage for us when moms deliver at that hospital.
Counselor Duffy?
Thank you, Madam Chair, and through you, Nikki, thanks for the presentation. I just want to maybe sort of dive a little deeper into what Councillor Metcalf just asked about there. So my question, I think, was somewhat similar. The referrals are coming from outside of the community, but just to be clear, those are for people that are residing within our community. It's just the referrals are from other sources. Is that correct?
That's correct. We have a system, the ministry provided system, where other hospitals or all hospitals are required to report births, and it's connected back to through their postal codes back through our jurisdiction. So we follow up with those from Haldimand and Norfolk.
Counselor Linda?
Thank you very much, and through you. Just to follow up again on that. So when you talked about the jurisdictions, you talked about Brantford, you went to Hamilton, you went that way. What about the London area? Because the West End is well served.
Yes, sorry, I just named a few of the hospitals, but any hospital we receive the referrals from.
No, go ahead.
Sorry.
I'm sorry.
So it's mandated. They're mandated to complete the referrals, and it automatically comes to us. However, we can't follow up with the client if they don't provide consent at the time of referral. So
I dive into that for a second. So if because I remember years ago, and that's a long time, when I had my children, there was someone that did come out, regardless of who you were, and back in the early 70s. And they all come out. But now you're telling me that when a child is born, someone attends to the mother and says, you can have this service for you if you choose to take it. Now, how does, and then here comes the question, how does that help identify the situations that could occur, like the high risk? How do you identify? Because 9 times out of 10, if it's a high risk situation, they're not going to say, come see me. So how do we square that circle?
You're correct. And that does pose a challenge because our program is voluntary. So we do try to provide as much information as possible about our program and the importance of our program. And we hope that in the hospital, they're getting that same messaging so that they can make an informed consent. However, it is a challenge that we do face in our program because they are not mandated. They do not have to follow up with us or do not have to consent to have their information shared with us so we can follow up with them following discharge. So we have discussed this because obviously it affects our referrals coming in and number of moms that we're able to connect with. So we try to obtain consent, or we're hoping to start obtaining consent sooner in their prenatal period so that so it's available as a service as support. They can see it as a support rather than something where we're going to come in and challenge what they are or aren't doing. So it's a supportive environment rather than where they feel they're being judged or anything like that.
And I think you make the point. I think it's getting to them prior to birth. I think from the doctor, there could be something that could be, or the doctors could tell them this is available to them if you want someone to talk to. And will there also be translation, because some of our area residents, moms don't necessarily speak the English language as best they could or can. And so is it important that you have someone to help translate some of that? And I'm talking about Low German.
Yeah, so we do have a family home visitor that can speak Low German. So when we do have a referral, that is the family home visitor that is connected, and she will be connected right from the beginning and will go out to the home with our public health nurse. We also have a partnership with the Norfolk Community Help Center, and they too have an interpreter. So if sometimes a referral may come directly from them, and so in the prenatal period, and so they act as the translator in that situation. As far as other languages, we haven't been faced where there's a need for translation. in addition to Low German Mennonite.
Thank you. Councillor Van Hassen.
Thank you, Madam Chair, and through you. Just wondering if you have any comments on my question asked earlier about the screening tools.
Yes, and so we do see a decrease, and you can see based on the numbers that I shared in my report and through my summary, we see a decrease. So that's why we want to start big with the capturing the most number of moms possible, because they do not have to work with us. So through the screen, they're identified as risk. That is subjective. So that is the assessor's assessment of that mom. And then so when we provide the opportunity, they still, many of them may refuse to join our program or don't see the need. The other piece is with risk on the screening tool is 2 or greater. So there may be a with risk, but it's significantly low. So there may be not the need that we would with our higher risk clients, and we focus our resources on those higher risk clients. So that's why you'll see a significant decrease in the numbers identified at risk. And as Dr. Locke said, the tool was reevaluated and it's used across the ministry. And for the last 5 years, there is different approaches where we prioritize the different numbers or the scores based on the needs in our capacity within the health unit. But so far, we're fortunate enough to be able to follow up with all the moms that are referred.
I could, Madam Chair. I think, like as Linda pointed out, that we want to get contact with every one of the new moms and get them the resources. But if I look at the numbers, we're spending like $1 million getting focused on less than 100 families. And I guess that is my question. Are we spending a lot of time and money chasing places that there's no need when those resorts, there are some definite need? And I think we said before, there are people, some of the ones that need it the most are turning it down, whether because that's one of the at-risk factors. Maybe there's a relationship there that's not the best and they don't want them talking to outside people. And how do we get more of our effort into where it's needed the most and less time shuffling paper to try to check the numbers on who should be having?
So one thing I didn't mention is our numbers for 2022 aren't very great and representative because we were picking back up from the pandemic. So in the beginning of the year, our team wasn't back at full capacity. We still had there was a lot of fear out there for having visitors in the home, et cetera, and using the program. So that did impact our numbers. It's not representative of what we would typically see. I forecast for 2023, based on our numbers already in the first quarter, we will see a significant increase in the number of families, and we have seen a significant increase in the number of families and referrals that are partaking in the program.
So I should just be quiet till next year when we get a full year in and we'll see how it's working. And hopefully all of life will be better.
Yes, I'm confident that we have and will see a continued increase in our number uptake.
Thank you.
I'll just add, thank you. I think that was a very good point because the objective of this program is to reach the most vulnerable people. And I just had a quick discussion with Dr. Locke. So the tool is from the ministry, but we can look and review some of the methods, how we are using that tool to get the maximum out of that tool or to reach the most vulnerable people. So we are going to do that. I think that was a very good point. Thank you.
Yeah, through you, Madam Chair, to the councillor. So your observation is not unique in that we noticed just before COVID, when I was at Southwestern, we were going to attempt to address that very issue about, first of all, making sure that our screen was done with more families, and then just following it through, but the program, the work that we're going to do got caught off with COVID. And I think the other issue that you're driving at is perhaps an evaluation of the new tool, how effective it actually is. Not only effective in terms of reaching the at-risk individuals and getting them engaged in our work, it's also the cost effective. Are we doing it in the most cost effective way? So I'll tuck that in the back of my brain. To get a sort of an evaluation done is a bigger process. But on the other hand, it is something that I could share. If that kind of evaluation was done, it would be almost something that would have to be led by Public Health Ontario across the province. But it's a good thing.
Thank you. Councillor Metcalf.
Yeah, just one quick comment, I guess, on that would be, we're seeing, 1,000 plus births a year in this region. And it's easy to say that we could, if it was a questionnaire or screening, that we would hit all 1,000 of those births. So to start there as a screening tool, it's like giving everyone in, Alderman Norfolk a questionnaire to ask or to fill out. So it'd be the same. So your numbers, you want, I think, the original screenings to stay high. And then from there, the evaluations may drop quite a bit, but I think you still want to reach as many births as possible.
Thank you. I think that's a great point, Councillor Metcalf. As a new grandma, my daughter used this service, and she has a check on her whenever she thinks she needs to. And I think all new mothers should be filling out this form. I don't know what your risk tool really looks like, but I think all new moms, they have their own idea and then they get home and think, gosh, this is not the way I think this is going. It shouldn't go this way. They haven't connected with the service. Now they're at home struggling because what they thought, not exactly how it is. So I don't know what the risk tool looks like. Maybe we need to reach out for education course during their prenatal period. Get some information out there that this is the service that Health Norfolk provides. Look at our risk tool. It is overwhelming when you bring that first baby. And also, we are attending Roma in August. Bring these forward to the provincial ministry. Is there any further comments? Councillor Van Hudson.
Thank you, Madam Chair. I have no technical expertise in a lot of this, but got a few little grandkids running around too. And the observation, every one of them is different and none of them came with an owner's manual. So no matter what you think is the right way, especially with the first time, and you read all the books you want, and everyone is different and they will do everything to mess with your head to screw it up. So again, to get that person to talk to sort of say, calm down, that's normal. They're just doing it on purpose to drive you nuts. And it only gets worse. But sometimes that's all it takes is that, and maybe it's the outside people from the health unit because apprehensively employed, but is it embarrassing to a new mom to admit that she's overwhelmed, that she's not going to tell her mother or mother-in-law or neighbors? And so if they got this outside help that can come in who does understand the problem, it's a little fireside chat kind of thing. It's probably a good thing that everything popped down.
Absolutely, Council. Councillor Duffy.
Thank you, Madam Chair, and through you, I guess my comment on this, and I appreciate the report and the importance of the work that you're doing. Our family's been a foster family for several years, and certainly some children have come into our home adverse situations. I think one of the things that we need to always be mindful of is sometimes expectant parents will bypass the screening tool simply in that sometimes they don't realize they're pregnant, and will be deemed risked at hospital at delivery time. So that will change our number. And I think from a communication standpoint, we need to also be considering, there is a degree of stigma to asking for help. Because sometimes there can be just the assumption that there will be intervention that may be contrary to what you're looking for. So I think, as we look at communicating what the program does, we really focus on the positive, that it doesn't necessarily mean that, there will be any sort of apprehensions or further. It's just literally there to help you, to support you, give you the resources, and really, really focus on the positive, because I think there is still there's a stigma to asking for help, which is collective across social services, but really focusing on the positive for sure. Thank you.
A good point, Kathy. That is very correct. Are there any other comments, Councillor Lindy?
No, but I'll make the motion to receive the report.
Thank you. All in favor? Carrie, thank you. Next up is 7.2.4 Infectious Disease Program HSS 23021.
Thank you, Madam Chair. Through you, I introduce Sarah Titmus, Program Manager for COVID Response Team, to present this report. Thank you.
Thanks, Syed. Good morning, everybody. My name, as Syed said, is Sarah Titmus, and I am the Program Manager for the COVID-19 Response Team. I have both the Infectious Disease Team and the COVID Response Team within my portfolio, and today we'll be presenting report number HSS 23021 Infectious Disease Program, and ask that the Advisory Committee accept this report as information. This morning, I will provide you with a high-level overview of the Health Unit's Infectious Disease Program from both an ID and COVID perspective. So what is the Infectious Disease Program? The program consists of many aspects executed by a number of different teams, including ID, COVID-19 response, vaccine preventable disease, and the environmental health teams. And as I mentioned, I'll be focusing on ID and COVID-19 response, and that team has a current complement of 10 FTE. Each team aligns its goals and thus its focus with the relevant sections of the Ontario Public Health Infectious and Communicable Disease Standard and associated protocols under the Health Protection and Promotion Act. For the ID and COVID response teams, the overarching goal is to reduce the spread of transmission of diseases of public health significance and protect the health of the Haldeman Norfolk communities through public health interventions. These interventions at a higher level include case, contact and outbreak management, surveillance and trend identification, communication and health promotion, infection prevention and control, infection prevention and control complaint and lapse investigations, and the Mandatory Blood Testing Act. In order to accomplish these higher level interventions, the ID and COVID response team also maintains partnerships with community agencies to enable collaborative work as well as a systematic approach to health promotion and community development. So why does it matter? What is the public health burden to the community? Well, in 2022, the teams investigated 664 diseases of public health significance in the areas of respiratory, enteric, sexually transmitted and bloodborne infections, tuberculosis, vaccine preventable diseases, and vector-borne diseases. The top 5 diseases of burden, excluding COVID, were influenza, chlamydia, Lyme disease, gonorrhea, and pertussis, with the Haldeman Norfolk jurisdiction being above the provincial average for Lyme disease and pertussis. We also have a provincial average for IGAS that is slightly higher, as well as COVID-19 cases. In 2022, we investigated 6,858 cases of COVID-19 and a total of 11,398 cases since COVID was included as a disease of public health significance in 2020. There have been significant changes to case and contact management throughout the 3 years, and so those numbers for 2020 are definitely underreported. Diseases of public health significance can lead to adverse outcomes such as long-term side effects, hospitalization, ICU admission, or even death. They can also lead to outbreaks within our long-term care homes, retirement homes, hospitals, and congregate living settings, where individuals who are medically or socially vulnerable live and are more susceptible to transmission as well as adverse outcomes. In 2022, we managed 187 outbreaks, and since the beginning of 2020, we've managed 346 COVID-19 outbreaks. You'll see on the table in page 4 of the report, which is page 31 in your package, that with the change in focus, we have seen an increase in our case management of outbreaks in 2021, which did decrease in 2022. However, the outbreaks in our highest risk settings did quadruple between the 2 years. So what is the health unit's role in decreasing transmission of diseases of public health significance and protecting the communities of Haldeman and Norfolk? As I briefly mentioned, there are 6 higher level public health interventions that the ID and COVID response teams are responsible for. And now we'll take a brief look at these areas. So as I mentioned, we'll start with case and contact management. There are currently 68 diseases of public health significance on the reportable disease list under the Health Protection and Promotion Act. This will increase to 71 this June. And diseases of public health significance are caused by pathogenic organisms such as bacteria, parasites, viruses, or fungi that can cause infectious diseases. These diseases can then spread from one environment or from one person to another, resulting in illness. Case and contact management involves an investigation of the case, including case management, health teaching, recommendations, follow-up, and contact tracing. So we look at things like isolation periods, return to work timelines, infection prevention and control measures to stop transmission, post-exposure prophylaxis requirements for things like influenza, HIV. Some diseases of public health significance also require things like test of cure or repeat testing to rule out increase in infection. And then, of course, contact tracing, where we look at who may also have been exposed and are there any precautions or testings that they need to undertake which can help decrease that transmission. This then can lead into outbreak management. And so there are a lot of the same aspects of case management, particularly for individual residents that are involved. And then there are a number of outbreak enhancements that take into consideration the entire outbreak area, which may be one floor of a hospital or a unit in a facility, or could be the entire facility. The team will collaborate with facility staff to define the outbreak and outbreak area, as well as investigate cases and contacts in the outbreak area. Facility level infection prevention and control guidance is provided, such as personal protective equipment for staff and residents, enhanced cleaning, and other items such as staff and resident cohorting. Testing recommendations and surveillance strategies are provided, and generally outbreaks are in place for an allotted time period, usually based on the incubation and infectability periods, and this is often a sliding scale based on the trajectory that the infectious disease takes. The team are also involved in some upstream prevention work, particularly with our facilities, where they attend their IPAC meetings and are involved in things like IPAC routine precautions, outbreak planning and preparedness, and occupational health recommendations. With all this also comes surveillance and trend identification. And this is a form of monitoring diseases of public health significance to identify trends and new emerging or increasing diseases of public health significance. Surveillance is undertaken at all levels, from the international scale to the national scale to the provincial and also local levels. An example of a provincial level surveillance is monkeypox, which is now being known as mpox, and we had 3 cases identified in our jurisdiction. Provincial level identification of this disease of public health significance allowed for coordinated efforts for health education, healthcare provider information, risk assessments, and immunizations. For example, the Gay Men's Sexual Health Alliance took the lead in developing health education, healthcare provider information, and risk communications that could then be adapted to meet each public health unit's need. We also ran locally run vaccine clinics and were able to offer mpox vaccines to 41 of our community residents. While doing these things, we also look at communication and health promotion. And as I already mentioned, Lyme disease was identified through local surveillance as one of our top 5 diseases of public health significance. We're well above the provincial average with 21.8 per 100,000 population. versus 9.2 per 100,000 population for the province. We are a Lyme endemic area, and so that means that the vector that carries Lyme disease, the mosquitoes, and the presence of mosquitoes who test positive for Lyme disease in our jurisdiction is high. And so it is imperative that interventions be implemented to reduce the risk of disease spread. The community needs assessment also identified that the proportion of participants completing tick checks after outdoor activity has decreased since 2019. Interventions already being implemented in this area include a modified two-tier lab test, updated clinical practice guidance, and information memos distributed to healthcare professionals to advise of these changes and distribute useful tools such as the clinical practice guidance document. The environmental health team and the ID team will collaborate this year on a VBD health promotion campaign. And so they'll be updating most of the public-facing health information we have on our website that we send out through social media, which includes things like a map of the Lyme disease endemic and risk areas, a focus on tick checks and tick identification and removal. It would be remiss of me not to talk about infection and prevention and control when I talk about the infectious disease and COVID-19 response programs. This is an increasing and expanding area of focus, with infection control practitioners traditionally being situated in hospital settings and now more broadly in long-term care homes, retirement homes, public health, and most recently the community IPAC hubs. And we have one infection control practitioner on our ID team who manages our IPAC program. Our program focuses on education, research utilization, surveillance and epidemiology, microbiology, outbreaks, and infectious disease threats. And some of the key focuses for 2023, as we move on from the pandemic here, will be a needs assessment of our community practice group that's been led by the health unit for a number of years. It has representation from all of our long-term care and retirement homes. They collaborate together and undertake mutual learning and disseminate information to strengthen the IPAC programs in our communities. We plan to do a gap analysis, so to identify gaps in IPAC programming provided through this community practice and ascertain what our colleagues need as we move out of the pandemic. We are also looking to expand our focus to childcare settings, and so we may end up with 2 different groups due to the 2 different population focuses. We also collaborate with our IPAC hub, where we coordinate and support the provision of IPAC knowledge, training, and expertise. That leaves us with IPAC complaint, lapse investigation, and the Mandatory Blood Testing Act. These remaining areas of focus have more of a legislative focus and occur less often, in part due to all of the previous high-level interventions undertaken by the team. All IPAC complaints received are taken seriously, and lapse investigations are undertaken to ascertain if there is a breach that requires mitigation. Mitigation includes public disclosure, health teaching, annual inspections by the environmental health team, and information/knowledge tool dissemination. The Mandatory Blood Testing Act also involves a formal and sometimes legal process for obtaining blood samples post-bloodborne exposures. The majority of MBTA requests are resolved through the formal process, and applicants are mainly first responders, police services, paramedics, Good Samaritans undertaking first aid, and victims of crime. Providing this process allows people who have been exposed to bloodborne infection to receive treatment if required, for example, HIV post-exposure prophylaxis, and also the information they need to self-monitor for signs and symptoms, as well as know what to do in case they do become infectious themselves. The risk of developing a bloodborne illness from a high-risk activity, such as a needle stick injury, is low risk, but it is not no risk. Both of these areas, so IPAC complaint and lapse investigations and the MBTA, are time-sensitive and resource-heavy and are an important part of decreasing the infectious risk to our communities. As you can see, the ID and COVID response teams have a large part to play in monitoring the health of the Haldeman and Norfolk communities from an infectious disease perspective. Preventive action through the public health interventions briefly described help us to reach our goal of reducing the transmission of infectious diseases and thus the disease burden within the Haldeman and Norfolk communities. Thank you for your time. I'll open it up to questions.
Thank you very much. Questions, comments? Councillor Duffy?
Thank you, Madam Chair, and through you, Sarah, thank you for the report and for the work that you're doing. I want to zero in just briefly on the local Lyme issue and the significance and prevalence of it in our area. So I note that the provincial average is 9.2 per 100,000 population. In 2019, we were 10.9, so already ahead of that number, and currently at 21.8. So that's fairly significant and quite concerning, I believe. I read in the report about the things that we have done in terms of two-tier testing, etc. What I'm curious about is what we're doing at the root cause of the issue, or what can we be doing at the root cause of the issue through mosquitoes and the ticks and things that are transmitting this disease. What more can we be doing?
That's a really good question. And so some of the things we really need to focus on when it comes to preventing Lyme disease is that unfortunately the ticks that carry Lyme disease are present in our communities. It is quite challenging to eradicate those. There are things that you can do for yourself personally, though. So whenever you're out doing outdoor activities, don't do things like walk barelegged in tall grass. Make sure you're wearing long sleeves. Tuck pants into your socks. Wear light-colored clothing. You can use insect repellents containing DEET, and they are useful and should be sprayed more onto your clothing rather than your skin. And it's really important to conduct a tick check on yourself and your family or your pets after you've been in a tick endemic habitat. The main reason for that is that a tick needs to be on your body for a certain length of time, so at least a 24-hour period before it's going to transmit Lyme disease to you. And so it's really important to get those ticks off as early as possible. I hope that answers your question.
Thank you, Councillor Linden.
Thank you. Through you, Madam Chair. Is there a possibility, and Lyme disease is rampant and ticks are everywhere. They're on your grass, they're in your trees, they're everywhere. So you can mow till the cows come home and you have this well-groomed area to walk about and children outside, but that you do get ticks. Is there a chemical that you could spray, a yard spray or anything like that? Because we have to be cognizant we're doing more harm than good. At the end of the day, sometimes putting a pesticide on that, so there's more risk that way. But is there something, have you heard of anything natural or non-invasive to people that a person can use?
There are some natural products out there. I would highly recommend that if people are using natural products or any product, that they're definitely taking all of the other measures of making sure they're in the right clothing and that they're doing those checks. But there are definitely some natural remedies that can be used. I know a lot of people talk about using citronella, adding a Vaseline, believe it or not, to wrists and ankles can be helpful as well. But you're right that it is very challenging to be spraying large areas of agricultural lands because, of course, we are destroying that natural habitat as well.
What you're saying is if I'm killing a tick, I'm also killing a bee, or I'm killing, yeah, I see your point. So it's more of a personal thing that we should be dressing properly and using the right chemical-based naturals to protect you from the actual tick.
That's correct.
Thank you, Councillor Van Passen.
Thank you, Madam Chair. Another one of the stupid questions here, but I can go to the vet and buy pills that I give to the dog and they don't get any problem with the ticks. How come I can't go to the pharmacist and get pills that I can eat? They do taste a little bit like licorice.
That is a very good question. I know that particularly with pets, they are also looking at expanding the time that pets take the tick medicine for. So rather than just doing it seasonally, they're looking at going to the whole year because of global warming more than anything, and we're seeing much warmer springs and falls than perhaps in previous years. My knowledge on this is that right now there are no like medically drug approved medications that you can take for Lyme disease. There are prophylactic medications that you can take for things like malaria, which is mosquito borne. They do have to be taken though for a consistent period of time, and they do have a lot of very adverse side effects and can unfortunately cause things like psychosis. So of course, if you are ever taking medications for anti-malaria pills, then it's really important that if you're having any side effects that you talk to your doctor so that they can get those changed for you. But unfortunately, that seems to be the case, is that those medicines aren't yet as well developed as perhaps they should be. Some bugs are more tricky to treat than others, for sure.
Thank you, Sarah. I just have a few questions. So you talked about the lab tests that we do here in Ontario. Now, I know we used to have to send those lab tests out to the states for testing. Have we upgraded that here in Ontario for testing of Lyme disease? I know we used to have hard time diagnosing that. So I wonder where those testing has been updated or not.
Yes, of course. So the 2-2 testing is done here in Canada. It usually starts out at the National Microbiology Lab in the early spring, and then they move that out to all of the local Public Health Ontario laboratories. So that can be done now within Ontario. One of the biggest changes, not just with the 2-tier testing, but is this focus on early detection. So the clinical practice guidelines for physicians are really kind of flip that coin to look more at those risk factors. So were you in a risk endemic area? Was the tick on your body for more than 24 hours? Do you have any signs and symptoms? And to start treatment early, even while you're waiting for the test result to come back.
So the bottom line is that it's pointless to test for the tick infection early. So I have to go back and maybe Sarah can remember better than I can. But at minimum, it's about several months because they only can test for the antibodies for it in your blood, and that takes a while to form. So the direction is that people should watch out for ticks. If they have a tick that they think has been on their body for more than 24 hours, then they should see their doctor. And then the doctor can decide whether or not to provide them antibiotics, because that's the only thing that you can do early on. I think that's what Sarah, am I sort of revisiting what you said just a little bit differently?
Yes, absolutely.
Yeah. So that just again, so we do the testing in the province. We have very good testing done at Public Health Ontario. I think they've just updated their testing protocol. I remember you're just an advisory about that very recently. But the key thing is that there's just no point in testing early. So if you had a tick bite yesterday, it's not like you're going to get a blood test tomorrow. It's not. It's more for the diagnosis of chronic Lyme disease. Chronic Lyme disease are those things where you have symptoms in your neurological system or your cardiac system, sometimes on your skin. That would be a long time after you had the tick bite, so you might not even remember that tick. At that point in time, you can use.
Thank you.
Yes, so just a follow-up then. The blood test would be for the person who's been bit by a tick. The process of some do, and I don't know if they do that in Ontario anymore, is they test the tick. They don't do that anymore.
So that is correct. We have moved away here from testing of individual ticks to what they call tick dragging. So every year the environmental health team go out and they drag for ticks in the bushy and woody areas of our jurisdiction. Those ticks are then sent to the National Microbiology Lab where they're tested for Lyme, and then a risk map is put together that shows kind of where our endemic and risk areas are within Haldimand and Norfolk. So our risk areas are predominantly, just find that for you here. Long Point to Port Dover into Langton and Symptom. Then the remainder of Norfolk County is considered a risk area. So the first 3 are endemic areas. And then the southwest corner of Haldeman is also a risk area. So there's kind of a strip that goes up the middle between Norfolk and Haldeman that's so far not considered an endemic or a risk area. But I think the bottom line is we are an endemic risk area. And so if you are out in a wooded area, make sure that tick prevention is top of mind.
Thank you for you, Madam Chair. Just to augment that response. Ticks were tested in the past, not as a pathway to help treat the patient who was sick. Ticks were tested as a surveillance thing to find out in a given area, do we have ticks that are carrying Lyme disease? That methodology has now changed to this more systematic tick dragging. So where they will have a sort of a wet sheet, I guess, that you systematically drag along the ground through an area, and then every single tick on that sheet is then tested, and that's a better surveillance methodology. So then back to the patient. What about them if they got bitten by a tick? So the bottom line is, if it's a black-legged tick, so there is a benefit for if a person has a tick to pick it off of them and put it in a little jar and show it to the doctor. Because if it's a black-legged tick, then what we do, because we are an endemic area, the doctor assumes that that tick is infected. When we're endemic, I think you only need one in, remind me, Sarah, but 1 in 20. It's actually only a very low number of the ticks have to be infected to be called endemic. But so even if you have a black-legged tick, it's probably unlikely it carries Lyme's. But still, because we have enough ticks with Lyme's, if you go to the doctor and you have a black-legged tick, then that doctor should just treat you with antibiotics if it was on longer than 24 hours. So the tick testing becomes less relevant for the patient. It's really only for surveillance purposes.
Thank you. Councillor Van Passen?
Thank you, Madam Chair, and I don't know if I read this right or not, but isn't that high dose of antibiotic one of the things you can go directly to the pharmacist now and not have to bypass the doctor? If you had your black-legged tick on you for more than 24 hours, just go to the pharmacist, get the shot, and that's about the best we can do.
You are correct that is just being released to the pharmacist, that they can provide antibiotics for Lyme disease post a tick bite. So that is definitely something that they can and will be starting to do, just as they're able to do antibiotics for other minor illnesses. So that will definitely increase people's ability to get antibiotics and to get them as early as possible.
Through you, Madam Chair, I'll just add as well that the 24-hour cutoff is actually very, very, very conservative. It probably takes more up to 72 hours for the tick to be on you to transmit Lyme. But just to play it really safe, they sort of advise that they've been on more than 24 hours in the antibiotics, but it's a very conservative recommendation.
Thank you. Sorry, Sarah, I would just like to ask about the education around Lyme disease in our area, as well as education on STDs, as they seem to be in the top 5. So I was just wondering about what education.
Yes, of course. So we do a number of different health education topics. On our health unit website, you will find Lyme disease as well as other vector-borne diseases listed, such as West Nile virus. You will also find information on STIs, so chlamydia, gonorrhea, syphilis, HIV, hepatitis C. And we do have a school team of nurses who go into our schools to provide education to teens on sexual health, as well as on sexually transmitted infections. We also have moved to doing a lot of social media posts, as we do find, particularly with our younger populations, that that's kind of where they go and not necessarily our old and boring health unit website. So we do very regularly post out on Facebook and Twitter around things like STIs. In fact, around most of the diseases of public health significance and what the signs and symptoms are and how to protect yourself from getting them in the first place and what to do if for any reason you do get one and how to get treated.
Thank you, Sarah. Is there any other questions?
For you, Madam Chair, again, this is where, apologize, maybe Syed and Sarah can correct me, but this is where a partnership with the municipalities can be of good help. If, you know, for Lyme disease, if we can get some more signage out parks about ticks and those spaces where people walk their dogs and stuff like that would be helpful. Sure, that's been done in the past. Yeah, every year it's worth revisiting.
Thank you. Is there any further questions? None, can I get a mover, please? Thank you, Councilor Linda, seconded by Councilor Metcalf, all in favor. Thank you, Carrie. Next is social services and housing, 7.3.1 homeless prevention program update funding 2023-24 HSS 23-026.
Thank you. Through the chair, I'll be presenting this report HSS 23026. But before I do, I wanted to introduce my team members who are here virtually and in person, who are available to answer questions. So we have Louise Lovell. She's the program manager who oversees the homeless prevention services team. And also Jessica Horton, our program manager of housing services. These two individuals work very collaboratively because housing and homeless prevention are part and parcel of a larger spectrum. And so they're both available to answer questions. And I will thank them preemptively for their help on some of the data and information that was gathered to complete the report. And also with us today is Heidi Van Dyke, the General Manager of Corporate Services, who previously was the Health and Social Services General Manager, and so is graced us with her presence to answer some questions where needed as well. So you can see it's a team effort. This report is a big one. There are a lot of recommendations in the report. So my first thing that I want to say to the committee is that we are very pleased about this announcement. This is extraordinary news for Halton and Norfolk. Our budget was nearly doubled. I would like to share with you as well that that's unique across the province. Many other service managers did not see very much of an increase at all. Some did, but to be doubled is unique. And we feel very strongly that this is a reflection of the work that our team has done, and also a reflection of the ministry's ability to understand and recognize our need to expand our services and support throughout both counties. So we're very, very happy to be here with this information. The reason that we're doing this outside of the budget process, I think, is probably fairly straightforward in the report. We found out on March 24th, which was clearly past the budget process. And so our original assumption had been much lower than the updated version, which is just 3.6 million and change. So super excited to have this amount. The report breaks down each of the different areas, the service areas that we are tasked to identify to the Ministry of Municipal Affairs and Housing, how we're going to spend these funds within each allocated category. And once we have gone through the council process and receive approval, then we will provide that investment plan to the ministry and let them know that that's approved and we can move forward with those plans. So that's how that mechanism works on the back end. I wanted to highlight a couple of the things within the report, and then I would like to probably just delve in a little bit deeper as we move into questions, because I feel like that's where we're going to be able to dive in a little bit more, where you may have some questions about the recommendations that we're bringing forward and the thoughts that we have. So a large component of this is requesting 5 FTEs. The fact of the matter is that for our homeless prevention services team, human beings are a resource and a service. We directly deliver supports and service to the most vulnerable people in our communities. And so having more individuals on our team not only means that we can allocate funds more effectively and efficiently, but also that we, as human beings, are available in the community, meeting people where they are to provide the much needed supports and services that they are coming forward with. I don't believe it is any surprise to anyone that the housing crisis, the social assistance rates being frozen since 2018, the cost of living increase, all of the things that we're very painfully aware of have driven our service needs beyond our capacity. So we are working beyond capacity now. These funds will allow us to get much closer to addressing those gaps in service and managing the needs of the members of our community better. The other piece that I want to point out with the additional staffing is that currently, based on the demands and the service changes, our team are often asked to work individually or by themselves in the community. The needs of individuals are becoming more complex, and I would be remiss to not mention the health and safety aspect of having people working alone in our communities. In order to do the work that we need to do, we need to be available, we need to be present, but I need to make sure that my team are safe, and I need to make sure that they can go in pairs. One of the other staff in this list, I want to just mention why a program supervisor. We're looking for a boots on the ground supervisor who can be present on site where our staff are on community action tables, first point of contact for OPP. Again, the entire community is tasked with supporting individuals as the crisis continues, and we need to collaborate better together, and we need to make sure that our team members have the supports and resources to do their work. And then embedded in here, a few other things that I wanted to just highlight. Last year, we put out an expression of interest in an RFP for some additional supports for emergency and housing, supportive housing solutions. We obtained bidders and have contracts in place for Norfolk County. These funds would first of all allow us to continue those additional services, which would be amazing, but we did not have any bidders come through in Haldeman. And so the ask in here is for an exception to the purchasing policy to allow us to directly collaborate with our Haldeman County partners immediately and start looking for some solutions, similar or different. It really needs to be based on the needs of the community. We know that Haldeman and Norfolk are similar, but they do have some differences, and so it will allow us to delve into the differences and to obtain some appropriate level of service supports in addition to the supports that we currently provide. We are looking at also a significant increase in funding for some of our housing stability bank items. And so this would include things like eviction prevention through the last month's rent to move to a safer location or to provide utility arrears, that sort of thing. When we think about homelessness, I think it's easy for us to envision that we see people who are experiencing homelessness, but it's an entire spectrum, and a lot of our work is really done behind the scenes in preventing evictions, preventing homelessness in the first place. And so having staff and resources available to directly deliver to people who are in need, we may not see them ever experiencing homelessness, which is what we'd love to see. We'd really like to stop that before it becomes an issue or a challenge. And then for those individuals for whom it does, having additional support staff to help them find and maintain housing is the other side of that. So there's so much involved in addressing this appropriately that I just want to highlight that sometimes I think we forget about the before the homelessness is experienced, the types of work that we can do to prevent that in the first place. So a lot of the funding is also being allocated to stop that from happening, to ensure that people are able to be stabilized in their housing or find housing and are stabilized there. There are a few other components within the report that talk about our current emergency housing program, maintaining 24-hour security. Again, health and safety is a very big consideration for us as we move forward. A hot meal service once a day to ensure that the residents in our services are receiving nutritious meals. We don't have that in place right now, and so we'd like to do that very much. We'd also like to have funding to do our homeless enumeration program this year if the ministry advises us we need to. We're still waiting for the ministry to determine if 2023 is a homeless enumeration year, but we do need to bookmark some funds, because if so, and we expect so, then we'll need to make sure that we have everything in place in order to do a great job as we did last year for the last time and the time before that. And finally, I just want to point out that we're also asking for support in order to do a fulsome review of the entire emergency housing program within Haldeman. Such a review has not happened since 2016, pre-pandemic, pre all of the things that are happening currently, that we would like to get a deeper dive and understand if we are really making the best decisions, and as we move forward to make more long-term decisions, that we're doing the right thing for the members of our community, particularly the most vulnerable members of our community. So with that, I would like to open that up to questions. And as I said, I have my team here. And if Louise or Jess feel that they're able to answer the question or would like to add anything, they're just going to raise their hand, and Heidi will do the same thing so that we can best answer questions. Thank you.
Thank you very much. Councilor Linda?
Thank you, and I guess I'll start us off. I can see by the table where the dollars are being put, which is excellent. But I think it's really vital to do the assessment, where you're going with those dollars. Here's the question, because Haldeman Norfolk is vast, it's vast area. How do you get that information to best serve the needs of where you're at? Now, I'll go specific like to the hot meal program, or necessarily a food meal program or something, because not necessarily will people come into a physical building and get a meal because you're located here, but the need might be over there. So is there an area of you doing the assessment to find out where you're best served? And is there a program that you will have a bagged lunch type of deal that you could drop? You can see them when you're going out and give them some fruit or vegetable or whatever in a bag system to be able to at least touch point with, because it's so vast. So to me, it's so difficult to try to do that program. Thank you.
So thank you, Madam Chair, through you to Councillor Vanden Drieschie. So I think that in terms of the looking at the emergency housing program, and specifically related to looking at options for Haldeman, what we want to do is really engage with the partners at the grassroots who are interacting people, local downtown business owners, churches, charitable organizations. As Stephanie mentioned, through the RFP process, we had some of those partners come forward in Norfolk. We want to do a deeper dive in both counties, but specifically in Haldeman, so that we can see what options are going to work best. We've been trying with the social services relief funds, as committee is aware, to have more of a spectrum of emergency housing services. Everything from you have a room for 24 hours a day with staff on site for support and hot meals, to you're not ready to come inside yet, so you can come have a hot meal, cot to sleep on, and a continental breakfast and a brown bag lunch to go, as we work with you to try to hopefully move you along the spectrum to more inside permanent housing. In terms of the geography, this team has had 3 housing support workers, 1 intake worker, and 3 housing support workers to travel the 2-county area. And the team has done amazing work since it started. The reality is that it is very challenging to have people, to be able to send people out in pairs across the 2-county area. So having more staff resources means that we can do that more efficiently, and we can be on the ground in the communities more often and less time travel. So I think that, the 24 years that I've been working in social services in the 2-county area, our unique geography, which is amazing, is also something that we are always tasked with being creative to see how we travel that 2-county area as efficiently as possible.
Thank you. Counselor Van Passen?
Thanks, Madam Chair. And through you, biggest thing I can notice here, we want to hire 5 more staff. One part I don't get is why is everybody a specialist? Like we have job description. Gotta hire somebody to make a list, by the name list. We're gonna hire somebody who is gonna do something with the people that are on that list, and then we have to hire somebody to deal with the data that's in the list. Why can't we just hire 3 people with the skill set that can work together to do all of those things at any given time and overlap and not give every job such a very fine, detailed description of what they can and can't do?
Oh, sorry, go ahead, Louise.
Sorry. Thanks. Through the chair to Councillor Van Passen, I will field that question for you. We actually don't have staff that are sort of pigeonholed into very specific roles. We have 3 housing support workers currently, and they're tasked with the direct delivery of 3 programs in their entirety. So the team collectively delivers the services of emergency housing, housing support for the chronically homeless in the community, and the by name list together. For the ease of presenting it to council for understanding, we group it in a way that you understand that it does take a body to manage each of those things. But the way they do it is actually quite coordinated and integrated. Part of the reason for that as well is that you want to reduce the contact for people in re-traumatizing them and telling their story over and over and over again. So we deliver those 3 services in a way that minimize that for the people that we're supporting.
This was one of the things in the back of my head, that this is part of the sales job to make sure the Board of Health commits to hiring more people. And they're all collectively support workers working on the same thing.
Correct.
So Madam Chair, if I could also just add, when we're looking at providing direct service to the people that we work with, we do need to have a certain skill set and level of experience and also credentials in order to make sure that we're providing appropriate service and that the staff member is maintaining appropriate boundaries, for example, and remaining safe. So that's where, for example, our staff in this program who work directly with people, they generally have education and background in social services or in human services or in addiction and mental health. And that is a different, although as Louise said, we collaborate and cross over as much as possible. But the reality is there are also administrative and data related needs on this team that is sometimes a different type of education, experience, and skill set, just like any other team in the corporation.
Thank you. Councillor Duffy?
Thank you, Madam Chair, and through you, just a few questions, and thank you for the work that this team is doing. I would say that with 3 people, you are certainly very strapped, covering a 2-county area, and it is vitally important. I guess that maybe kind of brings me to my first question, because I certainly do believe and support the comment in terms of keeping our staff safe. So I'm absolutely right there with you. I guess I am wondering though, because you do have a lot of ground to cover, and I have a little bit of awareness from this from my other life. But yeah, are there any other measures, call bells, emergency alert bells, that can allow staff to work independently? So that we can cover more ground. So it's not necessarily, I can fully see that there would be times where a team approach is important, but are there times where they can work independently and we can still provide safety?
Yes, through the chair, just waiting to see if Louise is going to chime in to you. Yes, there are, we do have, it's called a tracker, for lack of a better term, that we have all of our community-based staff have with them at all times. So that has allowed us to do some of the work absolutely individually without that additional staff person. So there is some availability for sure.
So just to sort of supplement that, so it's not necessarily that they will always be working in pairs. It will.
That's right. Absolutely. Sorry. Yes, through the chair to you. Yeah, it's not an assessment that that's going to happen all of the time. It's that when we need to or when we're unsure situation or circumstance, or if it's a larger type of crisis, that we would be able to at all times say, okay, send partners. But the absolute, they're not looking to staff ourselves in such a way that we're always in pairs.
Yeah, I'm looking to make sure we're spreading our resources.
Yeah, for sure. Absolutely. A great question. Yes.
I guess a couple of other questions. So are there instances where best practices from other municipalities are shared? I know you want to do sort of a more fulsome review. Will that also include looking at best practice?
Through the chair to the councillor, before I answer that question, I just wanted to follow up on the one that you asked directly before. So the other thing that we do as far as collaborating to go out is work extensively with our community partners, most often the OPP. So we are in contact with both community mobilization officers in Haldeman, Norfolk, and we are often escorted out by them. We're also working in tandem with the community paramedics quite often. The Parks and Rec departments, we often do partner with other community partners to get out as often as we can. The only challenge with that sometimes is, again, the time it takes to coordinate that. Often when we're trying to get out to see people, we got a report today and we want to try to get out to them today. So where staff can partner up to do it internally and free their schedules up, they try to get out and do it. But where there are safety or concerns about what we might encounter in the community, then we partner with other organizations and other staff. But that always is a challenge because it always takes a day or more to coordinate that as far as going out. In relation to the question about best practices, we most definitely sit on a variety of committees where we are constantly receiving information about best practices across the province. We work closely with the Canadian Alliance to End Homelessness. We work closely with OMSA. And there's several subcommittees of both of those organizations that we sit on, the Housing and Homeless Networks, in order to collaborate with our partners across the province. We, on the flip side of that, have also been highlighted as sort of pioneers in the way we're delivering service in a rural area. We have sat on a couple of community panels to highlight the work that Haldeman and Norfolk are doing, both with CAH and OMSA. So for sure, we're using best practices, current research, evidence everywhere that we can. And we're also sharing what we're doing to maximize resources in a small community, in a large geographic community, but small demographic community.
Yeah, continue, Madam Chair. Thank you. Okay, thanks very much for those responses. I see in the report and in the letter from the minister that the funding is confirmed for this year and planned for the next two, which is great. Of course, my question would be, what happens if that changes or once it stops? And at the point there, what can we continue to provide? What does that then look like? And what happens to those 5 FTEs?
Through the chair to you, that's always a possibility with any provincial funding. We're never promised funding for infinity. We saw some changes to our Ontario Works funding a number of years ago, and that significantly changed our staff complement and our spending opportunities. So I guess the reality is that we accept that could potentially happen. At this point, the ministry has been gracious enough to tell us that that's a planned allocation for 3 years with the intention that we make longer term plans. I personally would be surprised if they reduce it before then or thereafter, but Haldeman County had also reached out, and there's some comments in the report exactly in line with that. And so I'll answer the same as I did to Haldeman. We hope that it doesn't. I don't anticipate it doing so, but if it does change, then we will be coming back to you with a report to determine how our spending changes and what needs to change in terms of our staffing level. It is never our hope that we would reduce staffing complement, but it has been a reality in the past because we are funded through the province and they make the decisions on funding allocations from year to year. But again, as I said, seeing it mapped out for a 3-year period to me is a very good symbol that they're letting us know that they want us to work moving forward. The other thing, I think if I look sort of broader, the recognition that the federal government has also prioritized homelessness and housing and so on and so forth. So I would be very surprised if anything shifts in that, but it is always a reality with any prevention funding, unfortunately. And so we will continue to do the best work that we can, and we will bring information forward and make any changes that we need to assure that change in the future.
Thank you. Is there any further questions? I just want to say a few things. So since 2016, our homelessness has changed. It's no longer just the people with mental health issues that are out on the streets. People are losing their homes at a significant rate, and they end up in the streets. In fact, a family in Selkirk that is being evicted, they have new landlords. He has renovated a couple of units. Now they want that family out. This family has 3 children that are compromised and need a lot of supports, and they are going to be homeless. It is so sad. Our little community of Selkirk, and people are coming in and buying properties. Folks, it is very sad to see. So I am happy to see, and you're adding for workers here. We definitely need to be safe when we're out there, seeing families, seeing the homeless people, because you don't know what you're going to walk into. And I am happy to see that the province is funding this. Very good, and hopefully going forward, they will continue. Okay, so I'll get a mover, please. Councilor Metcalf, second by Councilor Duffy, all in favor? Carrie, thank you. Next is the 10-year housing and homeless plan, year 8, 2022, HSS 23029.
Yes, thank you. Through the chair, I would like to introduce Jessica Horton once again, who's going to be presenting this report for us. Go ahead, Jess.
Thank you, Madam Chair. I will be presenting report HSS 2329. As committee is aware, each municipality is required to have a 10-year housing and homelessness plan that outlines the community needs for housing and homeless prevention and strategies. The plan also outlines the actions that we plan to take over the 10-year period. So it is our guiding document on how we apply for funding and is the roadmap that we use to make those decisions. The province requires that we do this. When we submit investment plans, we have to link it back to this document. We are required to report on our updates every year to the ministry. We work with the building departments of both Haldimand and Norfolk counties to identify how many units and the types of units that were created. Some of the highlights that were included in the attached document are that we have successfully onboarded tenants into Dogwood Suites in conjunction with Indwell, which has provided our community with 51 units of affordable housing. Again, in partnership with Indwell, we've added 5 transitional housing beds in Simcoe to support the community as well. And in Haldimand, we have added 9 units of supportive housing, which were added in partnership with True Experience in Dunnville. So we have also supported 107 households with either a housing allowance or through the Canadian Ontario Housing Benefit, which is referred to as COB. And we also have the by name list up and running, which is now accepting referrals. My recommendation is that this report is received for information and that staff be directed to provide this update to the Ministry of Municipal Affairs and Housing in accordance with the Housing Services Act, as well as publish this on our Social Services and Housing website for both Haldimand and Norfolk counties.
Thank you, Jessica. Is there any questions or comments? None? Oh, Councilor Duffy.
We do move the recommendation, Madam Chair.
Thank you very much. Can I have a seconder? Thank you, Councilor Van Passen. All in favor? Carrie, thank you. Subcommittee reports, there are none. Communications, we have a 9.1 May Alpha info.
Thank you, Madam Chair. So this is just an update from Alpha to get members apprised of the latest news about public health, including any provincial announcements, legislation, and Alpha activities. Just for the information. Thank you.
Thank you. We also have 9.2, Hamilton Board of Health Correspondence 2023 PHS Annual Service Plan and Budget Submission Support for Sufficient, Stable, and Sustained Funding for Local Public Health Agencies.
To you, Madam Chair. So this is a communication from Hamilton Public Health sent to Ministry of Health asking for more funding for 2024. It's kind of an advocacy letter.
Yeah, discussion. Declare, and then a 9.3 declaration of emergency, Jones Tola from Hamilton.
Thank you. To you, Madam Chair. So this is again for your information. On April 12th, City of Hamilton, they declared emergency on 3 funds. The first one, homelessness, second, mental health, and opioids. And they sent these letters to different forums, including Ministry of Health, Ministry of Children and Community Services, Chief Medical Officer of Health, and Alpha. And we got this funding through HOMO. And this is again for your information. Thank you.
Thank you very much. Next up is, oh, sorry, Councillor Duffy, do you have a question?
Thank you, Madam Chair. If I may, Syed, I'm curious, are there standards that have to be met to declare the state of emergency on those issues?
So through you, Madam Chair, I'm not sure. I think this is the kind of a right of the council to declare an emergency, but I'm not sure about the standards on these 3 issues, but I can look into it.
If I may continue, thank you, Madam Chair. Thanks, Syed. Yeah, I am curious as to how that would compare population-based to Norfolk County and Baldwin County as well, and see, collectively, we've talked about this today, and it's an ongoing conversation in our community about this challenge that we're facing, and if there is merit to creating that state of emergency, and if it makes sense, I'm curious to leave that with you. Thank you.
There are criteria. I don't remember what they are, but they were looked at before COVID, so we can look into them again. Secondly, the reason we shared this is because as an information item. From my understanding, Hamilton is the 3rd community to do this. So I think Ottawa's done it and Toronto has done it. It speaks to the fact that dealing with homelessness is becoming a significant challenge, which is overwhelming these municipal resources, and therefore they felt that perhaps additional action could be, or additional funding, the resources could be obtained through declaring an emergency. And as stated, homelessness is a growing issue, and that's this was shared with you purely for awareness raising about what's going on elsewhere, and we'll continue to follow that story.
Thank you. Councillor Lindbeck?
Thank you, through you. It begs the question for our area, mental health and opioid use. What is the situation in Halton and Norfolk, specifically with the opioid use? I know that we had a significant problem, and your predecessor was, we were hoping it would take up the challenge. Have you noted, or have you seen an increase in the use in this area, or has been reported, or how do we go about finding out if it is increasing? I mean, we know that homelessness is moving forward, but not always, and with mental health, but the opioid use that's in the community. You noticed anything there, or can you give us any information?
Yeah, I'm too new here to be able to answer that question, but that said, there are surveys done, national surveys, from which we can gather data on substance use. So they are surveys that are self-reported. Of course, they're biased by the answers to those questions, but there is data out there. So we'll look further into it and find out what numbers we have. terms of substance use and the types of substances in our region, and then we could compare them with similar regions like small, urban, rural across the province, as well as to the provincial average, if that's possible.
Thank you. And the reason I ask that is because just a visual. When I walk around and I come to something or certainly or whatever, I'm seeing more people in distress than I have in the past. And I'm wondering, how do we scale that? And when do we call that an emergency? Because if I'm seeing it now by the library that I never saw before, or I just took a note, I was in the mall the other day, that I've never seen this, and there were people there in distress. And I thought, this is getting to be, if I can see it, then the numbers behind it are probably increasing. So I'm just hoping, because I take Councillor Duffy's point, what is the criteria that causes us to say that we have a crisis? So hopefully you'll look into that. Thank you.
Any further discussion? None? Thank you. Thank you for the communications today. There's nothing under other business. We do not have a closed session. The next meeting is Monday, June 26th. And can I get a mover to adjourn? Councillor Duffy, seconded by Councillor Metcalf. All in favor of adjournment at 11:22. Carried. Thank you.